ESMO Breast, I have presented in an educational session a review of a oral presentation regarding the biomarkers that could potentially inform treatment decisions in HER2-positive metastatic disease. Indeed, at the moment, for therapeutic decision, we still base our decisions on HER2 status and hormone receptor status. However, we also know that there are many potential sources of heterogeneity within HER2-positive disease. And I have reviewed those that hold the greatest promises in the next future to become potentially useful for patient stratification and treatment selection. And as a first issue, it is very important to highlight that there may be changes between the molecular status of the primary tumor and the metastasis. And for example, there is a quite large proportion, not negligible proportion of patients that for whom the status of the estrogen receptor or the HER2 changes between the primary and the metastasis. And although sometimes these changes might be related to technical issues, there are many studies that now have demonstrated that there may be also the possibility that a true change in tumor biology have occurred. And therefore, the biopsy of the metastatic site is nowadays supported by international guidelines, especially when the disease course is unusual. However, it is still unclear on which phenotype we should base our treatment decision. And I think that we should always integrate this result of the metastasis biopsy with clinical judgment, because the final goal is to provide the most personalized treatment to our patient. And a first source of heterogeneity within HER2-positive disease is the target itself, HER2. We are used to dichotomize tumor samples in HER2-positive and HER2-negative. However, the expression of HER2 is a continuum across all breast cancers. And therefore, there might be an implication of low levels of HER2 expression in patients categorized as HER2-positive by classical parameters. For example, there are some suggestions that TDM1 may work less in patients in patients with a low HER2 expression. However, we should not base our decision on the use of TDM right now based on the level of HER2 expression. And there is a more interesting aspect, that is that new antibody-drug conjugates, anti-HER2 antibody-drug conjugates have shown clinical activity in early phase clinical trials in patients categorized as HER2 negative, although expressing low levels of HER2. And this results, if they will be confirmed in further studies, might be very important, because they could open the opportunity to expand the pool of patients that could benefit from anti-HER2 therapies. Another important source of heterogeneity is gene expression, in particular the molecular intrinsic subtypes. We now know that within HER2-positive disease, we can recognize all the main intrinsic subtypes, and some of them might have implications for prognosis and therapeutic decisions. In particular, in HER2-positive metastatic disease, those patients with hormone receptor positive expression and a luminal phenotype may be the best setting to develop and to test effective combinations, including anti-HER2, endocrine therapy, and CDK4/6 inhibitors. We also know that the HER2 enriched molecular subtype is the one that is the most HER2 addicted and shows the highest rate of responses, for example, in after neoadjuvant treatment in the early setting. And within the HER2 enriched subtype, a high level of expression of HER2 is able to discriminate those tumors that are really, really most sensitive to anti-HER2 therapies. And in particular, in the neoadjuvant setting, these tumors might achieve a high rate of pathological complete response with chemo-free regimens with dual anti-HER2 blockade. So in the metastatic setting, patients with HER2 enriched and high HER2 levels may be those that might derive the greatest benefit from chemo-free effective anti-HER2 combinations, and this is an hypothesis to be tested in clinical trials. HER2 expression may also be heterogeneous within the same sample, and HER2 heterogeneity might have implications, for example, in regarding treatment with TDM1. This has been demonstrated in a neoadjuvant study, showing that those patients with heterogeneous HER2 expression did not achieve pathological complete response after TDM1 plus pertuzumab, as compared to more than 50% of patients with a homogeneous HER2 expression. And the poorer performance, the worse performance of TDM1 in case of HER2 heterogeneity has also been suggested in a post-hoc analysis of the Marianne trial in the metastatic setting. And whether the new antibody-drug conjugates, thanks to the more pronounced bystander effect, will be more effective in case of HER2 heterogeneity as compared to TDM1 is an hypothesis to be tested. Another source of heterogeneity can come from DNA mutations, in particular PIK3CA mutation that occur with a high frequency in HER2 positive disease, 20 to 30% of the cases. And there are some suggestions from, for example, from studies that evaluated the inclusion of drugs targeting the PI3K/AKT pathway together with trastuzumab and chemotherapy for metastatic disease, that the presence of PIK3CA mutation or in general biomarkers of PI3K pathway activation may indicate those patients that might derive the greatest benefit from this strategy. And there are studies ongoing evaluating the role of PI3K inhibitors in PIK3CA mutated HER2 positive metastatic breast cancer patients. I have also reviewed the role of immune biomarkers. We know that HER2 is an immunogenic subtype. HER2 positive disease is an immunogenic subtype, a breast cancer subtype. Indeed, tumor infiltrating lymphocytes can be found frequently in this disease with a wide dynamic range. And we also know that a higher presence of TILs is associated with response in the neoadjuvant setting to chemotherapy and anti-HER2, to prognosis, both in the early setting and in the metastatic setting. And this has led to the evaluation of immunotherapy for HER2 positive metastatic disease. And there are, in particular, two studies that have evaluated these strategies. And briefly, they tested different combinations, but what they found was that patients with PD-L1 positive disease were the ones probably most benefiting from immunotherapy combinations. And together with PD-L1, the presence of high levels of tumor infiltrating lymphocytes was another biomarker associated with response to immunotherapy. So probably to further develop immunotherapy for HER2 positive metastatic breast cancer patients, we should focus on PD-L1 positive and or high TIL patients, and probably the integration of these two biomarkers is will be more accurate in selecting those patients more likely to benefit.